Right, hello. Thank you very much for the invitation to come today. I'm really delighted to be here, and I'm really delighted to have a group of people together interested in the interaction between infection and diabetes. So I'm an infectious diseases doctor and immunologist, and I'm currently based in Oxford. My research interest is tropical immunology, and I've got a research group out in Thailand, and I've now founded a very small group in Oxford. My interest is vaccine development for intracellular pathogens. I've got particularly interested in Melioidosis, and because of my interest in Melioidosis, it has led me into my interest in diabetes just in the last few years. So I'm kind of following Danny and Danny's train of thought a few years behind, but very, very interesting area. So this is where I was based in Bangkok. It's a research institute that's Wellcome Trust funded and a collaboration between Oxford University and Mahidol University, one of the Bangkok universities. The thrust of the unit is actually very much malaria, led by Nick White, but there is a strong microbiology department that was really built up by Sharon Peacock, who was head of department there for 7 years. There's a very good BSL-3 laboratory that's CDC accredited, and the unit acts as a hub for the greater Southeast Asian region, with many areas accessible within an hour's flight. I spent a lot of my time in the northeast of Thailand, in Ubon Ratchathani, which is up here, close to the Lao border and also near to Cambodia. Sorry, I've used a very old map calling it Kampuchea. This is a view from the aeroplane in the wet season, and this is a lot of paddy fields in particular, which is the major industry there. This is the local hospital, Sapasit Hospital. It's a 1,000-bed tertiary referral hospital. It's very interesting spending time on the wards. It's an upper middle income country, Thailand, and the wards reflect this. There's an army of good nurses, very clean. There's intensive care, there's imaging, but they're not quite able to provide what we would be able to provide in Britain. Diabetes in Thailand, like elsewhere in the world, is very much expanding year on year, currently quoted at about 8% prevalence. It's predominantly type 2, although not that well studied. I've seen loads of patients in their 40s who don't look particularly fat to me. In fact, their BMI is usually around 25 upwards, so at the upper end of the normal BMI in Thailand, which is 18 to 23, and people tend to have central adipose tissue and less muscle mass. I did an HIV clinic in Bangkok for the Red Cross, where I had a lot of diabetic patients who were quite skinny. But I'm assuming from the limited data there is, it's mostly type 2. And speaking to diabetologists back here, of course, there's a lot of Thai people who live in the West who've been quite well studied with diabetes, and it does appear to be mostly type 2, but if anyone here has any more interest or knowledge, I'd be extremely interested to talk to you. So Melioidosis, Danny has already introduced. It's a horrible sepsis illness, sometimes described in med school as a funny TB. That doesn't really do it justice. To me, it looks more like a cross between TB and Staph aureus. It can be a very florid, febrile sepsis. People go to ITU and they're on correct antibiotics for the bacteria, which is usually usually meropenem or a similar broad-spectrum agent, and they carry on being febrile. They have microabscesses in their liver and spleen. It's caused by Burkholderia pseudomalaria, which is in the same family as Pseudomonas, and it's transmitted through the soil. It's also a potential bioterrorism weapon because it's hard to treat and hard to diagnose. And there's homology with glanders, and in the same group is Burkholderia capacia complex, which causes trouble, as you know, in cystics. In the northeast of Thailand, it's one of the major killers from infection, up there with AIDS and TB. The mortality of people who come to hospital and have culture-confirmed melioidosis is around 40%, and that hasn't got any better in the last 10 years. My own observation is that unfortunately some of this is a delay in the door-to-needle time, and sepsis management and paying attention to that is going to be part of the battle. We have 400 culture-confirmed cases a year at this hospital, Saposit, and probably around double that number if you include clinical diagnoses. All these cases are reported to the Thai Ministry of Health, but unfortunately the national website in Thailand for the Ministry of Health says the whole of Thailand has 10 cases a year, and we're reporting 400 from one hospital alone. My senior Thai colleagues at Mahidol have been to the Ministry of Health to discuss this with them, and they have said, find us a solution and we'll start publicising it, which is problematic for funding. WHO has not got it on a list of neglected tropical diseases. So Direk, who's our head of department in micro in Mahidol, has just published this very elegant study in the new journal Nature Microbiology, where he has built on the techniques used by the likes of Simon Hayes with spatial modelling, using data on soil, known Melioid accounts, known isolation of the bacteria from the environment, to make an estimate of the prevalence and the mortality. And he has actually estimated there to be around 165,000 cases a year around the globe, and it to be a global problem. You can see the confidence intervals are wide. It's a model, but it said all models are wrong, but some are useful. And I'm finding this a good framework to think about the disease. Under this model, 89,000 deaths a year, which is more than dengue, which shows the significance of the problem. And likely hotspots are India, Bangladesh, countries with huge populations, Indonesia as well, and possibly Nigeria as well. So there's currently a lot of research efforts to try and improve diagnosis in those regions. So overall, it's a neglected tropical disease, but it is being increasingly recognised, and it's possibly increasing in prevalence as well because of changing use of land, rising diabetes, and another risk factor is ageing, and an increasingly ageing population is doing the rice farming across Southeast Asia because of urban, the youth population moving to urban areas. So I believe we'll be hearing more of it. I was 4 years out in Thailand, and I spent my time trying to establish a study, an immunological study, and I studied people coming to hospital with acute melioidosis and followed them up for a year where possible. So far, I've got 200 cases of melioid in the cohort and matched controls. 2/3 of them have diabetes, which reflects what's coming in the front door. Unfortunately, in my cohort, a third die, and this is terrible. I don't actually recruit them until they get to day 4 of the study, of their admission, because I wait for the culture confirmation. So these are people who've survived the first 4 days of their sepsis admission. They're typically around 55 years of age, but with quite a wide distribution. And there's known to be relapse. The relapse rate is quite low here, so 4 out of 200 have relapsed over the 4 years of the study. And this may be because they're in a study. We're doing everything we can to make sure they get the 12 weeks of oral follow-on antibiotics that's recommended to prevent relapse. You can also see there's quite a long tail on the mortality, and some of the people who die are older people who look like the sort of patients who come in on a medical take. They have other comorbidities, and some of these people may die with the melioid, or the melioid may be a marker of end of life. The diabetic deaths tend to be part of the earlier ones. And so I use 28-day mortality as a cutoff to try and focus in on the melioid-related deaths. I've measured the HbA1c on everybody, and what I've found, using quite a conservative cutoff of 7, there's a bunch of people who come to hospital with known diabetes, and then there's also some new diagnosis made in people who come without diagnosis of melioidosis, but on admission they have a high HbA1c. I've also got a control group I recruit from outpatients, and it's interesting that there's really quite a difference in control here. What this says to me that it is possible to get reasonable diabetic control in insulin. This group of known diabetics who came to hospital with melioidosis, all but one were on therapy, and most of them were on insulin. So there is an attempt to control their glucose. Of course, these two populations are not the same. The outpatients represent people coming to hospital to engage in preventative medicine, whilst these people represent people sick coming to hospital. But you do wonder if this links into what Danny was saying. There's a little bit of evidence that if you have TB, it makes your glycemic control worse. And it's possible that having melioidosis, which can be subacute, this may be contributing to worsening glycemic control and playing a role in the diabetes burden. That's something we're interested in looking more at. If you have melioidosis, you usually make antibodies. This is measured by an IGHI assay, but they don't seem to help. I've been interested in looking at T-cell responses. So here I've measured T-cell responses to the bacteria by an interferon gamma ELISpot. And what I found that the people who survived as a group made a greater T-cell response to this intracellular bacteria than the people who didn't survive. And I don't see that effect with controls. And that interferon gamma seems to be coming from a combination of cell types, including CD4 and CD8. And interestingly, out of those who die, none of them seem to make a decent CD8 interferon gamma response. It's quite interesting when I look specifically at the diabetics versus the non-diabetics. And what I've seen that if you look at week 0, this is when people are coming to hospital sick. What I find is that the people with diabetes as a group have a lower response than the people without. So this is like a sluggish response. And then if you look at the survivors, they seem to have caught up, although they're still slightly behind. And of course, there's smaller numbers in the survivor population. But it seems to me quite possible that if you have diabetes, it seems to lead to a sluggish response to the bacteria, and there's some data of that in TB. What I'm now trying to do is model it, put it together to look at all the factors together, and try and look at the relative contributions of different components of the immune system and the diabetes. And I am finding that the T-cell response stands out as significant. Interestingly, the diabetics have the same survival rate as the non-diabetics, and that's quite interesting and something I'm trying to unpack. I've also had a look specifically in a project I've been doing with Danny and Rosemary Boyton. We've been looking at responses to a panel of proteins, and one finding I had was that people with diabetes seem to make a weaker response to GROL, 2 GROL proteins from the Burkholderia pseudomallei. So this is one particular area where the people with diabetes are failing to respond to the bacteria that we can look into some more. So in summary, melioids is a major cause of death and morbidity across the region. It's grossly under-recognised worldwide. The typical patient is a rice farmer in middle age with diabetes, and so there's a very well-defined market for a vaccine. A strong T-cell responses correlate with survival, so I think a vaccine is going to have to tap into that. And people with diabetes show these lower cellular responses, but no significant survival difference. So a huge number of people have worked on this with me, including Danny and Rosemary. Thank you very much.